Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press star 0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator for today, Ms. Christine Micah, Improvement Lead with the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Micah.
Hi, everyone, and welcome to today's Better Together eCollaborative Informational Webinar. As Val stated, my name is Christine Micah, and I'm an Improvement Lead with the Canadian Foundation for Healthcare Improvement, and I'll be your host today. As I introduce our staff and faculty, please take a moment to introduce yourselves and where you're joining us from using the chat box in the lower right-hand corner of your screen. We have a number of staff and faculty here on the call today, both as speakers and to respond to your questions. Speaking on the call today, we have Angela Morin, a passionate patient experience advisor, motivated to bring the patient and family voice to all levels of healthcare. Angela is a faculty member within the Better Together eCollaborative. She's also the co-chair of the Kingston General Hospital Patient and Family Advisory Council and a member of the Southeast Regional Cancer Center Patient and Family Advisory Council. Angela sits on the Board of Directors at Health Quality Ontario. Patricia O'Connor is another member of our Better Together eCollaborative faculty. She's also the Senior Advisor, Patient Engagement at the McGill University Health Centre and is the former Director of Nursing and Chief Nursing Officer at that institution. While not on the call today, Eleanor Revoir is also a faculty member with the Better Together eCollaborative. Prior to becoming an independent healthcare advisor, Eleanor was former Executive Vice President and the Chief Nursing Executive at the Kingston General Hospital, one of the Institute for Patient and Family-Centered Care's Better Together exemplars. Maria Judd is on the line today. She is our Senior Director at CFHI and overseeing the implementation of the eCollaborative. And last, but certainly not least, Jessie Checkley is a Senior Improvement Lead at the Foundation. Jessie led CFHI's Partnering with Patients and Families for Quality Improvement Collaborative in 2015-16 and is co-producing the eCollaborative curriculum and design. Jessie's on the call today to answer questions. Thank you all for joining us today. We are pleased to provide simultaneous interpretation for our on-call webinars. This may result in a few quick pauses in the dialogue today, and we'd invite you to participate in our chat box today in either official language. This is the second of 3 available informational webinars designed to provide prospective eCollaborative registrants with more information about the eCollaborative, and we have about 35 registrants on the call today. By attending today's session, we hope that you'll increase your understanding of family presence, both as a policy and as a practice, and understand how it can affect quality, costs, and patient outcomes. You will learn how hospitals are implementing policies that enable family members to have unrestricted access to their loved one during hospitalization. And thirdly, we hope to increase your understanding of how your organization can benefit from this eCollaborative. We'll spend some time talking about the eCollaborative format, content, activities, as well as the application process. Before going into the details of the collaborative, we'll spend a few minutes talking about the Canadian Foundation for Healthcare Improvement. CFHI is a national not-for-profit organization funded by the Government of Canada. We work to accelerate the spread of proven innovations by supporting healthcare organizations to adapt, implement, and measure improvements in patient care, population health, and value for money. Family presence is one innovation at the level of organizational design and service improvement that can have a profound impact on the culture of organizations delivering health services and result in improvement across multiple domains of quality. We fulfill our mission through our focus on 4 core areas as seen in the colored bubbles, all of which are central to the design of this eCollaborative. Patty will spend a bit more time highlighting some of the evidence for adopting family presence and how this policy change has the potential to improve quality. For now, I wanted to draw your attention to how family presence is viewed through a quality improvement lens. The slide is an illustration of the 6 levers of high-performing health systems based on research funded by the Foundation and conducted by Drs. G. Ross Baker and Jean-Louis Denis. Adopting family presence must be approached not only as a moral imperative, but as a catalyst for improvement. Adopting family presence, policy, and practice touches on every one of these levers. There are direct connections to creating supportive policies and engaging patients and citizens. Family presence policies and practice also serve to promote evidence-informed decision-making and will build on your organization's capacity while engaging frontline managers and providers in the adoption of family presence. From organizations who are leading the way in engaging patients and families, they have said that welcoming families was a catalyst for improvement across these 6 levers. Other quality bodies in Canada and around the world are recognizing the value of welcoming patients and caregivers as partners in care. The recent and significant revisions to Accreditation Canada's surveying standards are one example of support for the adoption of principles and practices of patient and family-centered care as a lever to delivering quality care. The E-Collaborative is one component of the larger Better Together campaign. The campaign was started in the United States by the Institute for Patient and Family-Centered Care. And their aim is to get 1,000 hospitals across North America to commit to adopting family presence policies that welcome family members as partners in care. CFHI is a Canadian organization partnering to spread the practice of family presence in Canada. As part of our outreach, we're thrilled to have 12 supporting organizations across Canada who are helping to raise awareness and bring visibility to this campaign. Before we go further, I'd like to stop here and offer a definition of family presence. As I've alluded to, it is both a policy and a practice. Family presence enables patients to designate partners in care who are welcome in the hospital 24 hours a day. Within the policy, there are specific elements that are central to family presence. Importantly, family is determined by the patient and may include blood relatives or other support people identified by the patient. Designated partners in care are welcomed 24 hours a day, 7 days a week. And lastly, family presence policies identify preferences for how families would like to be involved in care planning and decision-making. When it comes to family presence, welcoming families as partners in care looks different in different organizations. While some organizations choose to have an open visitation policy that does not differentiate between families and visitors, others choose to create a family presence policy that is specifically for designated partners in care and for whom access to their loved one is unrestricted while maintaining a separate and more traditional policy for visitors. The E-Collaborative will support family presence and will leave it to organizations to decide what model works best for them, while considering the exemplar criteria put forward by the Institute for Patient and Family-Centered Care regarding best practices in family presence. I would now like to pass things over to Angela, who will spend some time talking about her experience and the opportunity that exists for hospitals to welcome family members as partners in care.
Thank you, Christine. And hello to everyone on today's call. I'm very excited about this new E-Collaborative and very much appreciate the leadership role CFHI has taken in supporting organizations in changing families from visitors to partners in care. I am a believer in the adage, which I think Maya Angelou is credited with, that people may forget what you did, but they will always remember how you made them feel. So please close your eyes. I'd like you to remove your healthcare provider, staff, leader, advisor hat for a few minutes and just close your eyes. Picture someone you love. Perhaps it's a spouse, a child, a parent, a friend. You are holding hands. They are sick or injured, scared, vulnerable. They're lying in a hospital bed in your organization, in your hospital. They hold your hand tighter and say, please do not leave me here alone. Please don't go. How do you respond? Do you say, I have to go, visiting hours are over, and leave? Do you say you will stay and ask your coworkers to make an exception to the visiting hours rules? Or do you say, because you can, I will be here as long as you need me? Getting rid of restrictive visiting hours, having a patient and family-centered family presence policy is about being compassionate and respectful of patients' wishes and relationships and allowing loved ones to be there as long as they are needed and involved in care as they are needed. But it is also about patient safety and quality of care. I'm going to take this opportunity to share a few stories with you about the people in the pictures on this slide. My mom, my dad, and my daughter Amanda. These experiences took place in 3 different hospitals over a number of years, and I suspect they are not exceptional to the experience of many family members. At 57 years of age, my mom was diagnosed with colorectal cancer. Once she was diagnosed, everything happened really fast, and before we knew it, she was waking up from a surgery with a colostomy and a long road of chemo and radiation ahead. The night after her surgery, we left when visiting hours were over and returned the next morning to find my mom distraught. It had been a bad night for her, and I vowed that she would not spend another moment alone in the hospital as long as she needed someone to be with her. This decision on my part to not leave when visiting hours were over was met with mixed responses by the staff. For the most part, they were tolerant, but not terribly welcoming. Others embraced it and made me feel comfortable. I got her water, which was out of her reach. I comforted her in dark and fear-filled moments. I stopped her from pulling out tubes and IVs, and I talked her out of getting out of bed in the middle of the night and trying to make a run for it. I was there to hear the doctor's instructions and to ask the questions that we needed answered before taking her home. I was there to be part of her team, and I held her hand. I have to say that I have trouble comprehending how anyone would actually think that an organization or a policy or a complete stranger should have the right to tell me that I cannot, as a patient, have my loved one with me when I need them the most. To be brutally frank, I actually find restrictive visiting hours to be an archaic, insensitive, system-centered practice. Different hospital, 10 years later. My daughter, who was 22 years old at the time, had surgery to repair her broken hip. The night of her surgery, I was asked to leave, but was able to negotiate a few more hours with her. The nurse let me stay, but when the shift changed, the new nurse came in, and she insisted that I leave. She threatened to call security. So I unhappily left to avoid making a scene. When I arrived in the morning, my daughter was very upset. They had removed her catheter the night before, and she had to use the washroom during the night. She rang her call bell, but no one came. She was afraid she was going to wet the bed and was doped up on pain meds, so she got out of bed and, walking with her newly repaired broken hip, started to the washroom. The nurse caught her and scolded her for getting out of bed. That night, I stayed. No one forced me to leave. So what's that about? Sudden policy change? Staff change? New patient in the next bed? Fear of me going ballistic, maybe? No idea. No one told me why, but I was allowed to stay with my daughter. I got her the bedpan, held her hair when she vomited, repositioned her pillows, and I held her hand. Having a family presence policy in place means patients can partner with staff in determining who or if they want someone to stay with them, and relieve staff of the challenge of breaking the rules and circumventing policy just to do what is the right thing to do. It determines who the patient would like with them, who can partner in their care, who can help keep them safe. Last winter, my dad had to have a life-threatening cardiac procedure. In preparation of the day, my mom pulls up the hospital website and sees that there are set visiting hours. From that point on, she becomes stressed, not just about the surgery, but about the inevitable confrontation she's now expecting. There was no way, if my dad needed her, that anyone was going to make her leave that hospital. My parents have been married over 50 years. They are best friends. How could anyone think that forcing my mom to leave my dad's side, to let go of his hand if he needed her, was the right thing to do? Knowing an organization has a family presence policy that allows families, as defined by the patient, to partner in the care of their loved one is a huge comfort, provides peace of mind, and reduces anxiety and stress for everyone involved. Kingston General Hospital, where I am a patient and family experience advisor, has changed their visitation policy a few times over the years. It has evolved. It went from restrictive visiting hours to families welcome 24 hours a day. It went beyond changing the language to being more inclusive of patients and families to changing the intent of the policy. KGH is committed to creating an environment supportive of patient and family-centered care, positive health outcomes, and safety and security of patients, their families, guests, staff, and community, and the family presence policy is there to support and facilitate that. A couple of weeks ago, my husband had hip revision surgery at KGH. I was able to visit him in the recovery room and was included in the conversations with all of his healthcare providers. I was welcome to stay as long as I wanted. I helped him to the washroom, walked with him in the halls, and accompanied him to physio. I was made to feel welcome. This is not about allowing visitors to run amok or just getting rid of visiting hours. It is about dignity, respect, communication, information sharing, and collaboration. It is about changing the concept from family as visitor to family as partner in care. I hope that your organizations will embrace the Better Together campaign and consider joining the eCollaborative. It provides important guidance for staff and families, proven strategies for educating staff and for changing policies. For those struggling to get buy-in, it will lend support and provide data and measurement ideas. I know there are champions out there just looking for the commitment and support to make this happen in their organization. The Better Together campaign and eCollaborative is here to help, and the time to do it is now. Thank you for giving me the opportunity to share my perspective today. I hope you find today's presentation to be motivating and that it helps to provide you with a greater understanding of the value of having a family presence policy in your organization. As a member of the CFHI eCollaborative coaching faculty, I look forward to supporting the teams in the Better Together eCollaborative. We are better together. Now, with information regarding support of family presence policies and their connections to quality, I'm going to turn the presentation over to Patty. Thank you.
Thank you, Angela, for so eloquently making the case for family presence. In 2015, CFHI conducted market research to better understand the attitudes and beliefs of both the general public and the healthcare sector. We polled 672 health sector professionals and 1,006 members of the general public. In both instances, 90% of respondents supported family presence. Healthcare professionals did acknowledge they had some concerns. The eCollaborative is meant to create the space to work through these concerns together to develop and implement a sustainable policy. There's a tremendous opportunity to better meet the needs of patients, families, and staff by adopting family presence. We are calling on Canadian hospitals to join these efforts through our new collaborative. One way to consider the connections to quality is through the relationships between patient and family-centered care, patient engagement, and quality and safety. Patient and family-centered care is an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among providers, patients, and families. The Institute for Patient and Family-Centered Care defines 4 core concepts, and these include respect and dignity, information sharing, participation, and collaboration. Family presence is one policy and practice that espouses those core concepts. In welcoming families as partners in care, further opportunities for partnership will present themselves. Engaging patients and families in quality improvement leads to new insights and better outcomes than when providers are working on their own. These partnerships yield fruitful improvements in safety and quality. Research evidence supports the adoption of family presence policies. When family is welcomed as partners in care, the evidence indicates this often results in improved patient and family experience, fewer falls,
better coordination of care as family members can be jointly informed along with the patient of discharge instructions and changes in medications. And evidence also shows it results in fewer or a lower 30-day readmission rate. The Institute for Patient and Family-Centered Care has put together a facts and figures sheet highlighting evidence from the literature that offers support to organizations about the benefits of welcoming families as partners in care. This will be shared following the presentation. Over the course of the eCollaborative, teams will design their own measurement and evaluation plans and collect data that will support the sustainability of their projects. Through this collaborative, you will be able to demonstrate the tangible differences that family presence makes on your staff satisfaction, patient and family experience of care, and other quality metrics. The suggestion that families be welcome as partners in care in no way is meant to suggest the downgrading of clinical care to families. However, families know the patient best and can be your allies for quality and safety. This table has been adapted from a resource produced by Plaintree and Picker that outlines the ways in which families can be active members in care. Designated partners in care can help as a communication and education advocate, sharing progress with family and friends, and planning for care and discharge. They can offer emotional and spiritual support by coordinating visitors and communicating spiritual needs. Families play an important role in communicating the cultural and religious preferences of the patient, and they serve as safety advocates, reporting risks and concerns and communicating with staff about known risks of falls. Finally, families can serve as a physical support person to assist in activities such as personal care and providing comfort measures such as a hand massage. To act as allies for quality and safety, family participation must be welcomed and valued. There are a number of policies and practices that organizations can take up to create this environment. First and foremost, families cannot be locked out. Families need to be welcomed into the organization, and this begins with family presence policies. Many leading organizations have observed that family presence is the gateway to culture change that results in a number of practice changes to better support patient and family-centered care. Over the course of this collaborative, teams will be exposed to organizational practices that welcome families as partners. Some examples include welcoming family participation by creating orientation programs where families are given an overview of things such as whiteboards, the use of identification badges, inclusion of families in transfer of accountability and bedside report times. This list is not comprehensive, but provides you an idea of the potential for family presence to serve as a catalyst for improving the culture of patient and family-centered care. I'm now going to pass things back to Christine, who will share more information on the eCollaborative.
Thanks very much, Patty. We have saved lots of time for questions at the end of this presentation. If you do have questions or they've come to mind already, please feel free to type them into the chat box and we will return to these. The collaborative was designed to build the capacity of hospitals delivering inpatient services in order to undertake improvement initiatives, assess, plan, implement, evaluate, and sustain family presence, and introduce the practices that support patient and family-centered care in hospitals with inpatient services to improve patient safety and staff experiences and satisfaction. The eCollaborative is designed to meet the needs of Canadian healthcare organizations with inpatient services that are interested in adopting and implementing a family presence policy. We are looking for organizations who have not yet instituted family presence policies and show room for improvement on the openness of their visitation policies by scoring between 0 and 7 on CFHI's self-assessment form, which will be completed as part of the registration process. Eligible organizations may include, but are not limited to, regional health authorities, hospitals and hospital sites, including acute care, continuing care, rehabilitation care, and mental health care. We also encourage the participation of teams comprised of individuals from multiple organizations that provide services across the continuum of care. For example, we recognize that some smaller organizations have long-term care beds. Their participation would be welcomed as family presence would be spread across the entire organization. For organizations that score between 8 and 10 on the self-assessment, CFHI commends you on your open visitation policy. We would welcome your participation as a resource to others who can benefit from your experience and would encourage you to complete the expression of interest. While this collaborative has been designed for organizations who provide inpatient services, long-term care facilities will be considered if they feel this collaborative is a good fit for them. This collaborative is 11 months in duration, starting in May and ending in March 2017, and divided into 3 phases. Teams will be notified of their acceptance May 3rd, at which time Phase 1 will begin. All 3 phases are outlined in detail in the Better Together Change package on our website, which offers a detailed roadmap of the change to family presence policies. The collaborative is an adaptation of the IHI Breakthrough Series model. In each of the 3 phases, there will be learning periods, followed by action periods, where the steering committee will carry out a series of activities within their organization to support family presence policies. During each learning period, we will be offering 1 webinar, 1 coaching call, and 2 affinity calls. Affinity calls are a place where teams will come together virtually to discuss common challenges or themes, and these themes will be identified by teams through report updates and polls like the one that we'll conduct toward the end of the webinar. These facilitated calls will draw on our exemplar and leading organizations to share wisdom and their experience. Teams too will be able to share some of their success and challenges. Teams will be submitting progress updates each module to help identify challenges and successes and to build the case for change throughout the process. Teams will have access to a learning platform where all virtual components and communication will reside. Faculty, coaches, and staff will be available as additional support. Lastly, there is an opportunity and expectation for teams to interact with one another to share learnings and support along the journey. Full dates and details about the structure of the collaborative is available in our prospectus, and we will be accepting expressions of interest until April 22nd. We are inviting organizations to form a steering committee to oversee the adoption and implementation of family presence. There are 2 required positions that must be named on the expression of interest, which you will submit before April 22nd. Firstly is the executive sponsor, and this person will be responsible for ensuring connections to the executive team and oversight of all aspects of the family presence policy. They will be responsible for ensuring the voice of the patient and family caregiver, as well as staff, are considered through the policy change. The project manager will directly oversee the adoption and implementation. They will ensure a detailed work plan is developed, as well as the resources and responsibilities that are in place to meet the objectives and deliverables. The project manager will be responsible for the submissions of progress updates and end-of-phase reports. In addition, organizations are strongly encouraged to consider including individuals from a number of areas of expertise and accountability, as are displayed on the slide. You will have until mid-May to finalize the composition of your steering committee, but we would welcome your identification of the committee members as they become known as part of your expression of interest. In some contexts, when organizations have greater infrastructure and capacity, they may choose to create a subgroup that takes on some of the steering committee work. This may result in a smaller steering committee that meets less frequently, but has a direct and regular communication with the subgroup. If a subgroup is formed, the executive sponsor will commit to being briefed on a regular basis on the status of the initiative to enable activities and overcome barriers and challenges. This initiative is really about collaborating with patients and families. The formation of your steering committee is one way to start modeling what you expect to see in your own organizations by working directly with patients and family members as part of your team. We strongly advise the participation of a patient and/or family member on your steering committee team. So if you haven't already, you should be speaking to your advisory councils, your patient relations departments, or other patients within your organization to begin conversations about partnering for this initiative. In this prospectus, we have outlined 6 objectives and 8 deliverables, which will be achieved through your participation in the collaborative. Ultimately, the objective in entering the e-collaborative is to adopt and implement a family presence policy. To achieve this overarching objective, teams will gather information on their organization's current state and set the foundation for situating family presence as a quality improvement initiative. Teams will develop a current state report that includes an organizational environmental scan of the current state of visitation, a readiness assessment, and a stakeholder engagement plan. Teams will then identify the structures and processes required to facilitate and sustain environments that welcome the engagement and participation of patients, caregivers, leaders, and staff when adopting family presence policies. Your implementation plan will reflect how the steering committee plans to address these barriers and facilitators to design your improvement with sustainability in mind. Third objective is to bring attention to other family presence practices beyond opening the doors of your organization. During the collaborative, teams will gain exposure to practices such as the one described by Patty earlier on, and identify one or more practices that will become a priority quality improvement initiative during or following the completion of the collaborative. The fourth objective of the e-collaborative is to learn from one another, to obtain the knowledge required to support adoption, implementation, and the sustainability of family presence. We will be engaging with organizations who have already implemented family presence policies to share lessons learned, and there is an expectation among all collaborative participants to contribute to the collaborative in sharing your own experiences and asking for help when needed. The fifth objective of the e-collaborative is to understand the difference family presence can make, using appropriate measures to track changes related to the introduction of the policy. These include quality metrics as well as measures related to staff satisfaction. The sixth objective is to develop a shared understanding of how engagement-capable environments can serve as a catalyst for organizational change. You will document your progress through regular report updates and progress updates. In the 11-month e-collaborative, during this time span, we would expect that teams will have begun to implement their family presence policy and practice. We are inviting expressions of interest from organizations until April 22nd. This slide summarizes the 5 steps to submit your expression of interest. They can also be found in the prospectus as well as on our webpage. We are asking all prospective e-collaborative teams to complete the Better Together Pledge. This pledge identifies your organization's commitment to moving forward with family presence. Organizations who do not feel the e-collaborative is a fit for them and who may already be implementing their family presence policy are also invited to pledge. CFHI will bring visibility to your organization's efforts by posting all pledging logos on our website. Step 2 is completing the self-assessment. This self-assessment was adapted from CFHI's baseline study on visiting hours in Canada, released in November 2015. Teams will receive a score out of 10 based on their answer to 10 questions related to the openness of their visitation or family presence policies. In this collaborative, we are looking for organizations who score between 0 and 7 on the self-assessment and do not yet have open visitation. You're already completing step 3 as we go. This is to find out more information about the collaborative and to ask questions. If you do have questions, we are coming to our question and answer period. So again, I would invite you to chat in any questions that you have, and we'll return to questions in just a moment. The Better Together e-collaborative prospectus contains all the details discussed during this webinar. and we would encourage you to read this document in full before submitting your expression of interest. And lastly, step 5 is the submission of your expression of interest, available from our website as an electronic form. I would like to direct your attention to the number of resources that we do have available on our website. If you haven't already done so, please have a look at our website and the following documents of reference. At this time, we're going to take questions. And to get you thinking about some potential areas where your organization would benefit from support, we invite you to answer the following poll. These might be some topics featured on our affinity calls. We're inviting you to identify the top 3 areas that would be most helpful in supporting the adoption of family presence, whether that be safety, security, change management, quality improvement, patient engagement and partnership, measurement and evaluation, or other topics that we haven't listed but you're really looking for help and support. If you do identify the other, please chat those in to let us know what those topics are. I'll just give everyone a few moments to complete the poll. At this time, I am inviting questions. It looks like we may have a few already, so we'll just pause for one moment and then we'll start reviewing the questions. Hi, our first question is from Kathy at Labrador Grenfell Health. She's asking, are there circumstances where an open policy would be rescinded, such as an outbreak or emergency codes? Christine? So thanks, Jesse. I think in one general statement about how we would like for organizations to adopt family presence, and really what we're hoping is that the principle of patient and family-centered care are central to what you're doing in terms of welcoming families as partners in care. However, we will not be prescriptive when it comes to what your policy in your context looks like. So Kathy, certainly there are organizations who have been dealing with this. When you're talking about outbreaks and emergency codes, for example, I think those are 2 very specific examples of situations where not everybody has moved to full family presence, and there is a reason for that. As Patty alluded to, when we polled healthcare providers, there were some concerns, and certainly infection control is a big one, and we are looking to sort of work with teams to sort of navigate those and dealing with situations such as outbreak situations. When it comes to emergency codes, certainly that is another area or another part of the practice of family presence that some organizations have chosen to include in their family presence policies. However, we are not making this a necessity or a requirement in terms of what goes into your family presence policy, but that certainly is one of the practices that if there's an interest and appetite, we could expose organizations to and connect organizations who are interested in developing your family presence policy to include emergency codes. If there are other questions, certainly we'd welcome them by chatting into the chat box. I'll just wait a few more moments to see if there are additional questions. I see we have chatted the response, so there were a couple of questions related to circulation of the slides. We are happy to circulate these, and these will come following the webinar in the next few days. So certainly anyone who is registered, you will receive the slides, as well as the reference sheet Patty was referring to, the facts and figures, and some of the evidence for supporting family presence policies. So we are here to answer any questions that you may have. If you're sort of lingering on questions, certainly don't hesitate. We're welcome to those. I also include my email at the end of this presentation. So thanks very much for an excellent presentation today, both from Angela and from Patty, and thank you all for being on the call and for those who have asked questions and answered our polls. Very helpful for us to hear what's on your mind. We hope that you found this session informative and will join us again in the near future. On April 21st, join us for our recommended learning journey on Indigenous health by participating in this webinar, Building an Indigenous Mental Health System of Care, Part 1. Our on-call learning opportunities are available free of charge. For more information, please visit our on-call page. Your feedback is invaluable to us for future webinar design, so we ask that you please take just a moment now to provide us with some feedback on today's session. And we will continue to remain on the line for any further questions that are arising. If you still have questions about the subject matter, certainly we're here to answer those. Please chat them in to the chat box. So again, thanks for completing the polling questions. This is invaluable feedback for us in terms of understanding how we're doing on our webinars. So please let us know if this call has helped you decide whether or not to apply to the actual e-collaborative, whether it increased your knowledge of the Better Together e-collaborative. We'd like to know your intentions on assessing your organization's readiness to apply. And lastly, your general satisfaction with the webinar. If you have any comments or questions, there is an open chat box. You're welcome to type your answer in there as well. And sincere thank you to all of you for being on the call with us today. I do see a couple of people typing in questions. Again, we will remain on the line for any further questions that arise.
We have a question from Jill. She's asking, in addition to measuring staff satisfaction, will patient and family satisfaction and experience be measured?
Thanks, Jill, for the question. Maybe, Patty, I'd like to pass that over to you in terms of measurement and what we're looking to measure, and the openness of really what the measurement plan will be for teams. Patty?
Sure, be happy to. Jill, it will depend on what your organization is already measuring. But in general, we think that it's going to be important to have some very simple, basic measures on at least two areas. One is staff satisfaction with and their understanding of your current practices and policies, and then the reactions as you engage in making changes in terms of encouraging family presence. So monitoring how staff react is going to be important. And that can be done through a number of ways, and we'll be talking about that in some of the earliest of the sessions once the teams join. The other area that you definitely are going to want to do some tracking in terms of outcomes is the reaction from patients, families, and visitors. And that can take the form of formal surveys that your organization may already be using, such as the picker surveys, which are used in a number of provinces, and there's other ones like HCAPS or the Canadian Patient Experiences Survey. If your organization is not using a formal one, then what we will be doing is coaching teams on how to use some simple measures, again, pre and post, that you can use either with surveys and or very brief interviews with patients and family members to get their reactions to the changes in policy and practices that you'll put in place. There may be other measures as well, depending upon the organization's choice of whether or not you want to go beyond just the introduction of the family presence policies and modification of your visiting hours for visitors. That's sort of the basic. That's part of this collaborative, the basic expectation. But we'll also be introducing you through webinars and affinity calls to other practices that are considered, that have strong evidence behind them in terms of patient and family-centered care. And as we talk about each of those other types of interventions or strategies to strengthen partnerships, we'll also talk to you about the simple measurements that can be put in place, again, to see to what extent it's making a difference in your environment.
So thanks so much, Patty. If there are still people on the line, don't be alarmed. We're just changing the layout. The chat is still there, and we'll stay on for a few more minutes. If there are additional questions, certainly chat them in. If not, thanks very much. We are actually at the end of our webinar. We did leave lots of time for questions, and if those have all been answered, we're very happy about that. If you do have additional questions, you will see my email that is located on the slide right now. We would thank you for your participation and your consideration in joining the eCollaborative, and we look forward to hearing from you and hope that you apply. Thanks very much.